This presentation covers Case Study 1, focusing on Steve, a 33-year-old primary school teacher with chronic left ankle instability. 2 weeks ago, he rolled his ankle playing tennis, resulting in pain, bruising, and 1 week of crutch use. He now walks pain-free but with a slight limp, favouring his right side. Steve has a history of at least 5 left ankle sprains and reports occasional left hip and groin pain during sitting, deep squats, and tennis. He is motivated to return to tennis and squat without pain. Steve presented with chronic ankle instability, particularly on his left side. This can be characterized as continual lateral ankle sprains resulting in damage to the lateral ligament complex. Steve mentioned he rolled his ankle, which refers to excessive inversion of the ankle, resulting in ligamentous damage. The main ligaments that are damaged are the anterior talofibular ligament, or ATFL, which is the most commonly injured, calcaneofibular ligament, or CTFL, and then posterior talofibular ligament, or PTFL, also known as the lateral ligament complex. Repeated lateral ankle sprains will result in both mechanical and functional instabilities. Mechanical instabilities refer to anatomical changes that lead to insufficiencies in the ankle, such as laxity, impaired atheromechanics, and joint synovial changes. Functional instabilities refer to changes to the neuromuscular system that provides dynamic support to the ankle. Damaged mechanoreceptors in the lateral ankle ligaments resulted in proprioceptive and balance deficits. This would affect Steve's functional capacity and daily living conditions, as he would struggle to walk as his gait would be affected. Examples such as walking and going upstairs would be difficult, as his balance would also be affected. Steve presented with suspected left hip femoroacetabular impingement, or FAI. FAI is where there is abnormal contact between the femoral head and the acetabula during movements such as hip flexion and rotation, which results in soft tissue damage to the femoroacetabular joint. There are 3 types of FAI. The first, a cam lesion, is where the femoral head has an overgrowth of bone, creating a bump or abnormal shape that rubs against the acetabulum, leading to pain, stiffness, and potential damage to the labrum. The second, a pincer lesion, is where the acetabulum has an extra bony growth or overhanging rim, causing the femoral head to be overly covered, again causing a pinching of the labrum. The third is a combination of both cam and pincer lesions. This would affect Steve's functional capacity and daily living conditions, as he would experience pain and reduced range of motion and muscle weakness. The orthopedic testing reveals multiple positive findings that align with the client's reported symptoms and functional limitations. A positive talar tilt and anterior draw on the left indicate lateral ankle ligament instability, supported by pain and weakness during plantar flexion and inversion. The FATA test was positive on the left, with the anterior hip pain suggesting potential FAI, or labral irritation. This is reinforced by restricted and painful left hip internal rotation and flexion. A positive Thomas test indicates tight left hip flexors, contributing to altered movement during functional tasks. Range of motion assessments highlight significant asymmetrics. Left dorsiflexion is limited to 2 degrees on the left versus 13 degrees on the right, and hip internal rotation is restricted to 30 degrees on the left versus 50 degrees on the right. These limitations affect the client's ability to move efficiently and may contribute to compensatory patterns. Manual muscle testing revealed weakness in the left plantar flexors with a 3 out of 5, and hip adductors with a 4 out of 5, and external rotators 4 out of 5, all on the left, indicating deficits in key stabilizing muscles. In the functional testing, the client demonstrates poor single leg control on the left. During the single leg squat, excessive hip internal rotation and ankle pronation were observed, with limited depth due to hip discomfort. Balance testing showed reduced left side performance, with only 3 seconds maintained on foam, compared to 10 seconds on the right. The client also completed only 8 left-sided calf raises before stopping due to lateral ankle pain versus 21 on the right. These findings reflect significant left-sided instability, neuromuscular dysfunction, and pain-limited movement capacity. When looking at Steve's goals, he expressed that he is keen to get back to playing his social tennis team once per week. He'd also like to not roll his ankle and feel more stable through it whilst playing. Steve additionally wants to be able to squat without pain in his left hip and groin. As a practitioner, the short-term goals for Steve is to reduce his pain to equal or less than 2 out of 10, increase range of motion in ankle dorsiflexion from 2 degrees to 8 degrees, aiming towards symmetry, improve left hip internal rotation, range of motion from 30 degrees to 40 degrees without pain. His medium-term goals are for Steve to achieve symmetry or near symmetry in all manual muscle testing, dynamic balance tasks, and range of motion testing to 90% of each other to achieve overall global strength within his ankles. As a final stage goal, Steve would have full confidence in his ankle stability, performing sport-specific movements like lateral movement, jumping, and forward/backward acceleration/deceleration. The warm-up exercises that have been chosen are to set up the client Steve for the main session. As can be seen in the literature, the strengthening of weakened muscles is essential for rapid recovery and is a preventative measure against re-injury for chronic ankle instability. The warm-up begins with cycling as this is a low-impact exercise that will help take the ankle through its range of motion, increasing blood flow, and also working lower limb muscles such as gastrocnemius, soleus, and peroneal muscles. This is important as it has been shown that insufficient strength within the peroneal muscles is associated with chronic ankle instability re-injury. Along with this, ankle dorsiflexion mobilization has been added to again help with regaining ankle range of motion. The warm-up also includes 90-90 hip stretch to aid in improving hip mobility and flexibility. This stretch targets muscles such as the glutes, piriformis, and hip flexors, which all play a role in hip FAI and contribute to pain and stiffness. As this is the warm-up, these exercises have been prescribed for 2 sets of 10 reps or 2 sets of 30-second holds at an RPE of 8 to 10 to keep it in the light stages. This is so the client feels warm and prepared for the main session. Isometric ankle eversion and inversion have been included to aid in the strengthening muscles such as peroneus longus, peroneus brevis, tibialis anterior, and tibialis posterior. By strengthening these muscles, it will aid in stabilizing the ankle joint and reducing the risk of re-injury through improved strength and proprioception. Similarly, with the single leg calf raises and isometric ankle dorsiflexion, working the muscles such as gastrocnemius soleus, plantaris, tibialis anterior, and extensor hallucis longus, aid in strengthening and stabilizing the ankle joint. By including these 4 exercises, the ankle joint is building strength through all 4 movement directions, leading to global strength and control, combating his chronic ankle instability, and reducing re-injury risk. These exercises were prescribed as 3 sets of 10 to 12 reps. Glute bridges with a band and side-lying leg lifts were added to address Steve's suspected left hip femoroacetabular impingement. By strengthening this muscle, it aids in providing his hip stability both at rest and in motion, an improved movement pattern, and pelvic stability. Specifically with side-lying hip abduction, by targeting the glute medius, this will aid in stabilizing the pelvis during movement, which was seen to be a deficit during the clinical assessment with his internal hip rotation during his squat. Additionally, dead bugs were added to the session as it can be seen that increased abdominal strength and endurance, which was important for the hip and pelvis. By having weak abdominals and pelvic floor, this can lead to compensatory pelvic and hip movements, such as an anterior pelvic tilt. This can worsen FAI as it increases the femoroacetabular contact. By strengthening the abdominals and pelvic floor, it will aid in teaching posterior pelvic tilt, encouraging better positioning, reducing the strain on the joint, and also relieving the strain put on the hip flexors as the glutes and abdominals are now working. Single leg balance has been added to the session to help train proprioception. This is crucial for chronic ankle instability as it will help restore neuromuscular control and joint awareness. By training and regaining this, the chance of re-injury becomes much lower. Finally, the cool down is the same as the warm-up to aid in taking the joint through its full range of motion to prevent adaptive muscle shortening. The only difference is Steve will have a 5-minute walk instead of a cycle to help retrain the neuromuscular connection within his gait. Safety considerations include ensuring Steve exercises on stable ground and avoids lateral or high impact movements early on. His response to exercise will be monitored using the RPE scale to prevent pain. Depending on how Steve presents, the exercises may be too easy or too difficult and will be adjusted accordingly. Additionally, education surrounding the injury will be provided for Steve. During the intermediate stage, Steve will be progressing to performing exercises under progressive load, so maintaining proper form is essential. This will be assessed through range of motion testing, palpation of relevant landmarks throughout the movement, and scores of 5 out of 5 for all manual muscle testing. Progression into the intermediate stages will require Steve to be able to perform all exercises with no more than a 1 to 2 out of 10 pain. Additionally, no increase in pain for the 24 hours following the session, as this can indicate poor tolerance. To progress into the advanced stages of the program, Steve must achieve at least 90% symmetry of his right hand side using the limb symmetry index. Along with this, experiencing no pain performing exercises. This will indicate Steve has the adequate strength and neuromuscular control of his pathologies. Exercises such as calf raises, handheld dynamometer reading for ankle inversion and eversion, along with hip internal/external rotation and hip abduction will provide quantitative data to help conclude this. Once this is met, Steve can progress.